Hi, I'm Sean Fix with Emergency Medical Consultants. We're a national training center for a number of organizations providing continuing education for healthcare providers, fire, EMS, and industry. This video series that you're about to look at is designed to help you prepare for a certification course. Remember that it's not designed to make you leave your required manual or not do your required pre-course exams prior to entering the course. It's also a great review just for clinical practice and relevance.
Though newborn resuscitation is no longer a part of the regular PALS class, we feel that it is important for some providers who may be faced with deliveries, such as remote providers, EMS, or rural clinics. When we're faced with an impending delivery of a newborn, we need to be prepared. We need to find out as much information from the mom as we can. For example, how far along is she? Does she have any problems? Does she have diabetes? Has she had problems with her blood pressure? Those are types of things that would lead us to believe that this might be more than just a routine delivery. Our objective in any delivery is to provide good patient outcome, and we want to resuscitate appropriately and obviously successfully. So things we're going to need to do is we need to have equipment needed to clear the airway. We want to support adequate ventilation, and we want to help keep that infant warm. So we need to know from mom if her water broke. If it did, what color was it, and how long ago was it? A prolonged rupture could be a problem for infection. We need to communicate that to the infant's providers. We also need to know if mom's on any medications, especially things that might affect the newborn. We want to know if this is a multiple pregnancy. Is she expecting more than one baby? So we use a thing called the inverted pyramid. Every single baby gets the first step, which is dry, warm position, stimulate, suction if they need it. Then that takes us about 30 seconds after the infant's born. And during that time, we're going to start our assessment of this infant. So as we're drying and stimulating, we're also looking to see if the baby has tone. Is the baby moving? Is their color starting to get better? Babies are born usually a purple color, and we ideally want them to become pink. But that doesn't happen very quickly. It takes some time for them to progress. So after the first 30 seconds while we're drying, warming, positioning, and stimulating, we're also assessing for crying. So we want to see what's going on with the infant. At 30 seconds, we decide, is the infant progressing? If not, then we need to intervene. So we ideally would want to start positive pressure ventilation at about 30 seconds of life. And we can start that with room air. We don't have to give oxygen unless the infant needs it. So once we start PPV, we're going to put on a pulse ox so that we can monitor their oxygen status. Just because an infant is cyanotic doesn't mean they need oxygen. So in order to progress, we need to make sure we're providing good positive pressure ventilation. This means that we have chest rise and that we have an increasing heart rate. We would assess the heart rate using the pulse ox value or an EKG monitor or actually auscultating for apical pulse. And we would adjust oxygen as needed based on the infant's oxygen saturation. There is a chart that we would use that tells us how old the infant is as to where their stats should be. Babies aren't born with an O2 sat of 95%, and that's normal. So when we're progressing through our ventilation, if we are not getting good chest rise, we cannot move on to the next step. So we need to do what's called Mr. SOFA. M means the mask. Do we have the right size mask? It's either an infant mask or a neonatal mask if the baby is small or premature. R is for reposition. We need to reposition the airway and avoid hyperextension. but we want to make sure that the airway is open. Next, we have S for suction. This would be the first time that we would suction an infant, only if they need it. O is for open the mouth, so in case there's some sort of nasal obstruction, we want to make sure that the mouth is a little bit open to help us to ventilate. P is for extra pressure. Normally we ventilate with a pressure of 20 to 25, but if that's not getting us chest rise, then we want to increase a little bit higher. And A is for advanced airway. This would be the point where we would intubate the baby if that's within our skill set, or else we would use an LMA that's size appropriate for the infant. That once we get good chest rise for at least 30 seconds, we reassess the heart rate, and then we would decide if we need to start compressions if the heart rate's less than 60. Once we start compressions, we make sure that we're using 100% oxygen on our positive pressure, and then we do compressions for 1 minute before we would advance to using epinephrine. Once we get to the point of epinephrine, first we can put it down the endotracheal tube. The dose down the endotracheal tube is 0.5 to 1 milliliter per kilogram. If we don't have the weight of the infant, we can estimate. You can use your size and length-based tape to assess the approximate weight of the infant. So we would say 1 kilo, 2, 3, 4, 5, etc. Then, once we give the epinephrine down the ET tube, we do not need to put a flush. It's diluted enough. We just continue bagging the infant. So the compression to ventilation ratio remains 3 to 1, even with an advanced airway. Unlike PALS protocol, we don't separate once we have an advanced airway. We stay coordinated. So once we've given the epinephrine down the tube, we need to prepare for IV access. So if able, we would put it on umbilical line or peripheral if possible. If not, we would use an IO. It just depends on your situation. Once we have an IO, we can go ahead and give the first IV dose of epi, and that would be 0.1 to 0.3 milliliters per kilo, which is 0.01 to 0.03 milligrams. And that needs to be given and followed by a flush. Did not have to wait the 3 to 5 minutes after the endotracheal dose, but we do start the 3 to 5 minutes once we've given the first IV dose. If the patient is still not progressing and we have signs of poor perfusion after the epinephrine, then we would progress to giving a fluid bolus. For newborns 28 days and less, the bolus is 10 milliliters per kilo, given slow and evenly. We don't want to give it as a rapid bolus. That would cause an increase in intracranial blood flow and could potentially cause intraventricular hemorrhage. Most infants do not require these advanced steps. Like I said earlier, 10% require the beginning steps, and only about 1% require advanced resuscitation. So besides epinephrine, in some situations it might be necessary to give naloxone. Depends on your practice area, and it depends on what's going on with mom. So if you have a baby that continues to be depressed or has a history of mom with some narcotic ingestion 4 hours prior to delivery, then the infant may need naloxone. This is given very rarely in the hospital, but in a pre-hospital setting, it may still be indicated. We also have some possible post-resuscitation complications. If you have a newborn that's doing fine and then all of a sudden starts to deteriorate, we need to check for an airway compromise. So we use the DOPE mnemonic. D is for displaced, O is for obstructed. We have to remember our ET tubes used in infants are very tiny, and it takes just a small amount of secretions to obstruct that tube. We also look for a pneumothorax, and then we always want to troubleshoot for equipment failure. So we would start with the ET, start at the patient and work our way back. As long as we can get a good ventilation with the bag, then we know that it's not the tube that's the problem. We also want to be aware of gastric distension. If you've been ventilating this patient for a while, they're going to have a full belly, so we need to put down an OG tube to decompress the stomach. One of the other things we need to be aware of throughout a resuscitation is trying to keep the infant warm. Depending on the environment, infants are at higher risk for getting cold. Once they develop cold stress, it's a very difficult situation to reverse. We want to be aware of our acid-base status. Always want to check the glucose early and frequently. And once we get to the hospital, they're going to do labs and x-rays and whatnot to further assess the infant. One of the most important parts of caring for a small infant is making sure we keep them warm. The best way to do that is to put them in a plastic bag. So the bag that we're using, it comes from the Ambu. We don't take the bag out, and we're going to put the infant inside the bag. We're going to close the bag as best as possible, put on a hat if we have one, and then we're going to wrap the infant up and help keep them warm and continue our resuscitation. This helps to prevent cold stress, which can cause higher infant mortality.